Thank you all for being here today. It's my pleasure to introduce a person who has been a wonderful colleague and friend for the last 14 years, I believe. And we've worked together in a paper, in a study, and the paper was just published yesterday in Lancet Global Health on Project Accept, which was a 48-community randomized controlled trial to see if community mobilization and HIV testing could reduce HIV incidence. And one of the important sites was led by Professor Richter in KwaZulu-Natal, where the HIV epidemic has been incredibly devastating. In our study, in a probability sample, we recorded 60% prevalence among women between the ages of 25 and 32. And that's a couple of years ago. And that continues to change. But besides that study, Professor Richter is a distinguished research fellow in the HIV, STI, and TB program. She's an A-rated scientist in South Africa, an honorary professor in the Department of Pediatrics at the University of the Witwatersrand, an honorary professor in psychology, and a research fellow at the University of KwaZulu-Natal, a research associate in the Department of Child and Adolescent Psychiatry at Oxford University. She obtained her PhD in psychology from the University of KwaZulu-Natal in 1981. She's had a long and distinguished career, and especially focusing on children, child development, and what it is we need to do to keep children whole and to give them the best possible future. This work has become even more important given the HIV epidemic in all of sub-Saharan Africa and other parts of the world, and the issues of poverty and other issues that affect young children. Her special emphasis is on research that can lead to better policies for young people. She will be moving from the Human Sciences Research Council in South Africa in a year to the University of the Witwatersrand, where she will lead a Center of Excellence funded by the South African government on child development. Linda, it's a pleasure.
Thank you, Tom. Well, thank you all for coming. This is an exciting time for me. It's the first time in LA, and I'm having a real Hollywood experience in my hotel. There's a boy band, an Australian boy band, by the name of 5 Seconds for Summer, and so there are crowds of young girls outside every day. But it's really an important time for Tom and I because, as he said, the main endpoints paper from the study we did together has just come out, and so it's a real time of celebration. And it's also a time for a little bit of reflection for me. I'm a 5th generation South African, and so I'm very much rooted at bottom end of the African continent. And yet I've had the privilege of working globally on issues related to policy and science with respect to children's development. So I'm the Early Child Development Advisor for the World Health Organization in Geneva, and I was seconded from my current position to the Global Fund to fight AIDS, tuberculosis, and malaria for 2 years. So I have a sense, and I thought what I would do is just go over what I think are some of the critical challenges in working globally, and particularly in joining up the various parts of the world. And what have been the breakthroughs and what have been the things that have really helped that work and advanced us? So the challenges of working globally is that we really don't know, and here I'm talking specifically about children, is we don't know enough. And I call it the 6%, 90% problem. We've had careful reviews in at least 3 areas, in psychiatry generally, in infancy, and in adolescence, showing that only about 6% of the published literature is about 90% of the world's children and adolescents. So we don't know enough. Secondly, we don't always use what we do know, and I hope I bring that out in my lecture. There's also a sort of rigidity about theory and methodology. It can be insular in a way that makes it less able to be used. And lastly, it might seem counterintuitive, but resources have a downside, and I will say why. So the lack of adjustment in theory and methods is that because so much of the theory and methodology comes out of particular places in the world, it tends to be somewhat insular and is somewhat unchallenged by observations in other parts of the world, in other contexts of culture and that challenge that. And so the theory becomes less useful. I was going to give you the examples of attachment and what is called proto-conversation. So the sort of conversations mothers and babies have, how are you, my darling, what are you saying to mommy? It has been stated in US literature that this is a population-specific set of behaviors, that it doesn't occur amongst other people based on some observations in Kenya. Well, given that we theorize that these proto-conversations are an essential part of the development of mentality and language, why isn't the theory and the methodology more accommodating of that? That is beginning to change, and there's a fabulous article by Maston in the recent Child Development on how theory and methodology in the study of resilience is adapting to findings from other parts of the world. Now, resources have a downside. This world map is just a kind of metaphorical world map which says that in the main, resources are concentrated up in the north, and in the main, the problems are concentrated down in the south. And this has a somewhat distorting effect on both science and policy. So let me give you the example of HIV and AIDS. There's been so many resources with respect to HIV and AIDS, both training opportunities, funding, exchanges, that it has created a distorted bulge in our science systems. We've just had a review in South Africa, and there's a distinctly distorted bulge where a lot of talent, a lot of money, a lot of effort, a lot of training is devoted to HIV and AIDS. It is a critical problem in our country, but it's not the only problem, so that other areas of science have been neglected. So that's one distorting influence of the resources. The other thing is the average country in Southern and Eastern Africa is getting about $30 to $40 million a year in only one aspect of children's programming, orphans and vulnerable children, from PEPFAR of about 30 million. Now that is up to the order of 20 and 30 times bigger than the fiscal allocations to social welfare in general in those countries. So you can see the impact that this is likely to have on policy, that domestic programs find it very difficult not to be completely overwhelmed by foreign assistance money. So many, as I said, we have quite a distorted science system if you're looking at dispassionately from a kind of science perspective, in that HIV and AIDS has been so well resourced over the last 15, 20 years that we have this distortion, and sometimes it distorts the nature of the science. So a lot of that money has come from NIH, with certainly in my field, in children and HIV, with US-type agendas. Other money comes from commissions from international donors. It's often focused on short-term interventions at the expense of longer-term determinant studies and longer-term outcome studies. I mean, Tom and I have been working on Project Accept for 14 years. That's a long-term study. Many are proof of concept RCTs, which are generally unscalable or non-scalable. A 28-session parenting program is never going to have a chance of being scaled up in a low-resource country. And many duplicate USA studies rather than innovate. So there are those challenges which have, in some ways, and I'll show you, have slowed us down, because we didn't always have the mechanisms for dealing with them, and we now have some more effective mechanisms. So what I want to talk about is what I call the distorting influence of folk theory and sentiment with respect to children and HIV, how we lost time and we misdirected our efforts, the correcting influence of global collaboration. I'm really a great adherent of global collaborations, and that how they can give good direction to both science and policy. And then just something that we've done over the last year and a half, which I believe is leapfrogging knowledge in this area, so that we're not having to go through this tedious process of reproducing studies that were done in the US, do them in South Africa or in Malawi, but actually saying, no, we can use the information we have to do completely new and interesting work. So Tom mentioned the scale of the epidemic in South Africa. I didn't work in this area. I was really working in the field of poverty and malnutrition. But the HIV epidemic is so compelling, so urgent in South Africa, so big, that really about 14, 15 years ago, this is almost the most of what I do. So that if you think about it, that in the province in which I live, 39.5% of pregnant women are HIV positive. That means almost every second woman. And we have had some very notable successes in HIV over the last 10 years. So this is the declining infections globally. This is UNAIDS data from 2013. And amongst children, we've seen the same thing. We've seen declining infections. There's definitely strong gains that are very encouraging. In addition to which, there's been a global effort to reduce mother-to-child transmission, and we're seeing the benefit of that. And the whole goal is to get to zero, and it does seem an attainable goal, and everybody is kind of holding hands to get there. On the other hand, the number of people living with HIV, that is the prevalence globally, is increasing. We're not getting on top of it. And deaths, although they increase, they are being brought down slowly by treatment, but nonetheless are not yet below the 2001 levels. And what does that mean for children? Well, that means that children continue to live with parents who have a chronic disease that needs to be controlled by medication, that drains family income, that drains family resources, and children continue to lose parents to HIV. And these are the children that I refer to as children in the epidemic. I don't like to talk about them as children affected by, children infected. I just talk about this epidemic has major ramifications for children. So one of the things is that science doesn't speak for itself. In the absence of good information, and as I've said, we don't always have good information, where there are kind of compellingly, emotionally driven issues, we tend to default to what some people call the kind of basic assumptions of our own culture. And these can run counter to contemporary scientific thinking, and they can lead to cognitive mistakes. This is how Shonkoff and Bales put it. But there's a long tradition in anthropology about what is called folk theory. And that is the use of one's own experiences and perspectives to intuitively arrive at things. And for a very long time, what was happening with children was very much driven by what I would call folk theory sentiment, not really understanding what was going on. And this had an impact on all kinds of aspects of the epidemic with respect to children. It delayed us recognizing pediatric AIDS. The whole blinding concept of an orphan kind of shielded us from recognizing the importance of families in the epidemic. For a long time, we've almost denied that people in key populations had any families. We've very much individualized our response to the epidemic. And with respect to the impacts on children, for a long time, we haven't really recognized that it is poverty, which is almost like the tipping point for children affected by HIV. And then I'll get to these correcting influences. So not seeing pediatric AIDS, there was really a very significant delay in recognizing pediatric HIV, which was related to the prejudice around the epidemic to start with. The idea that it was a gay disease. Peter Piot, who then most recently headed UNAIDS, had a paper refused. It did eventually get published in the Lancet in 2004, but in 1984, sorry. But the prejudice was so great that he actually faced refusal by journals for the paper to appear when he tried to write about heterosexual transmission in Zaire. Well, that had a knock-on effect on recognizing children, and it wasn't until 1990 that we actually accepted that HIV could be transmitted through breastfeeding. And this means that both prevention and treatment for children has lagged. So even though we're making this enormous effort to get to reduce infections in children and get women treated, only 63% of women in high prevalence countries have access to effective drugs. That drops down to as little as 30% in West Africa. And then only 50% of women have access to drugs during breastfeeding, which contributes about half of infection in children. And there's a huge new research area that I hope we're not going to see a delay in, and that is people becoming much more aware of the potentially toxic effects of ARVs on children in terms of stillbirths, premature deliveries, miscarriages, low birth weight, and potentially neurodevelopmental delays. So the kind of new frontiers opening up, which is really about making the drugs safer to be taken during pregnancy and breastfeeding for young children. Treatment has lagged. So while 64% of adults who are eligible for treatment are on treatment, only 34% of children are. And only 39% of children are being tested for HIV within 6 weeks, which means that treatment is being delayed for them, and therefore they're losing these very early developmental gains as a result of the exposure. So not seeing the importance of family. There's really been this blinding impact of the orphan data. The orphan data is really an epidemiological concept, and it led to the assumption that in Africa, children had no parents, there were no extended families, there were no adults to care for children. In fact, we have excess quantities of adults, we have low levels of employment. This wasn't true, but it came very easily with the notion of orphaning. Because gay people really pioneered the activism around HIV and rejected the very conservative views of family, which are sometimes promulgated in the United States. That added to a very individualistic approach to the epidemic in general, but also to children, so that a lot of the interventions, the psychosocial care and support interventions, were highly individualistic. They were trying to replace what was considered to be no family, and so we've seen a huge increase in the number of orphanages and institutions. Key populations, as I said before, men who have sex with men, sex workers, people who use drugs, were all seen as individuals, not connected to other people, whereas in truth, except for the United States and parts of Western Europe, most men who have sex with men have children. Sex workers have children at the same rates of anybody else, as do drug users. So children got separated from the mainstream of the HIV epidemic, particularly the big science and the big policy. And the binding influence of orphans was really the projections of the 3 stages of epidemic, from HIV infection, people living with AIDS as an illness and then dying, and that trying to emphasize the social impact of HIV, which was expressed as orphaning. And it refers technically to the death of one or both parents. The big numbers come from the death of one parent. But the tail began to wag the dog in this case, and so everybody became concentrated, not on a vulnerable family, that is a remaining parent with children, but on the idea of an orphaned individual child. So this is just a diagram from Wiseman Chirwa, who works in Malawi, pointing out the horizontal and vertical extensions of a typical Southern African family. That children have parents across horizontally beside their mother and father. Grandparents are considered in every way to be a parent. But they also have parents vertically with respect to an older brother is called a big father, an older brother of the father is called a big father, a younger brother is called a little father, and so on. So there is an extended family that really never got attention in the early parts of the epidemic. Double orphans are a quite small proportion of vulnerable children. Really, most of the major number of children who are affected are children living with a surviving parent, most often a mother, because male mortality is still higher than female mortality. 95% of orphans live with a family. Families are the de facto welfare system throughout low-resource countries. And so we missed completely for about 10 years the concept of the vulnerable family, that we really had to think beyond the child. And this is a schematic illustration by Jeff Foster in Zimbabwe, showing that even today, the family is, in fact, the bulk of the response, the bulk of the services that affected children receive. It is a UN indicator to keep data on families who get any external assistance. And the latest data we have is that still only 11% of households in epidemic countries receive any external assistance. So, it just emphasizes the point that if we are going to help children in this epidemic, we really have to be focusing on their families. And so we've seen this documented increase in orphanages associated with HIV and AIDS, which is most children in orphanages are poor rather than orphaned completely, as illustrated by the famous case of David Banda, who was adopted by Madonna. And it leads to a cycle of poverty. Anybody who's been to Mozambique will see that post their civil conflict, an enormous number of orphanages opened up in the country that were funded by war funds. Well, nobody's interested in war in Mozambique anymore, so you have orphanages now that have absolutely no flow of money, staff who have not received salaries for a year or more, children chained to beds, and so on. And you know, within the discipline of child development, within psychiatry and neurology and so on, it's just overwhelming evidence of the adverse effects of orphaning. And yet, this is one thing we haven't entirely stopped, but there's been a significant break on the establishment of orphanages. So what was the international response? It's really been spearheaded by the international NGOs that we all know, SAVE and PLAN and PATH and UNICEF and so on. But the biggest injection of the response came with the President's Emergency Plan for AIDS Relief in 2003. This is when these really very significant amounts of money became available. And today they still are the major source of funding for any programs for children in these poor countries. It's a significant amount of money. It's about $400 million a year. And of course, it is mandated and secure. So it's, the word earmark is not used, but that is in fact what it is. And that doesn't count the funds that are given to the Global Fund. In the beginning, those first 5 years, I was very lucky in the last PEPFAR review to be a member of the team that reviewed the work in orphans and vulnerable children in 26 countries. And we were able to get a bird's eye view of what was going on. And that first emergency response really consisted of training very large numbers of children and then funding international NGOs who defaulted to these highly individualized services that were driven by numbers. So it was about getting to children. And what in fact happened is the services became very distorted. So there were a list of 6 essential services, and shelter was one of them. We'll get a blanket to a child. Education was another. We'll get a satchel to a child. Enroll children in camps or after-school clubs, or do memory boxes with them. That was the first 5 years, and at the second 5 years kind of was beginning to adjust that. But as I'll tell you just now, the most recent recommitment is seeing a very different approach. The third thing that took a long time to recognize was the pervasive effects of poverty. Because this issue got tied up with another debate, and that is that HIV has taken hold in unequal and poor societies, and in those societies it's been better off people who've been most affected because they have greater mobility and so on. And that for a while has obscured the fact that HIV nonetheless impoverishes families. It leads to loss of employment, livelihoods, land, homes. I recently did a review when I was at the Global Fund, which was published in PLOS ONE, looking at cash transfer programs to assist people. And every indication is that the costs of treatment and death really can consume 100% of family income per annum. And the effects of HIV from study after study indicate that you can't distinguish any particular effects of HIV over and above those of severe poverty. So it is poverty, it is the families which are affected by HIV who are poor, who cannot protect children. So we know a lot from hundreds of years of studies of children in poverty, that they're both direct effects on children and they're indirect effects. And in one of the best known studies, which was led by UNICEF, looking at 60 nationally representative DHS and mixed studies in 36 countries, 3 robust indicators: wasting, school attendance, and early sexual debut. No effect of HIV, but distinguishable along the wealth asset index. So when we took stock of what we were doing, all of these supportive things that came out of phase 1 of PEPFAR and second phase of PEPFAR helped in one way or another, but they fell far short of what was needed and really had very little appreciation of the scale of the problem. Lack of guidance from the global community of scholars and practitioners, despite what had been learned from relief work and emergency work, from nutrition, education and health, very little of that filtered into HIV, which was very insulated partly by its resources. It didn't need to seek out other people. And so a lot of issues were reinvented, as I told you, the issue about not recognizing families, the issue of ignoring poverty, of allowing institutionalization of children. So just to give you an example of the kind of mistakes that were made, in Tanzania, $800,000 was spent over several years registering most vulnerable children. When they'd registered 785,000 of these children, the register was only 65% complete, and a third of the country's districts had yet to be done. During this whole period of registration, those children didn't receive a single service. This was this misdirected idea that if you could list all these children and then you would deliver services to them. So a lot of time was wasted, a lot of effort was wasted. But there are three very successful examples of how these trends that weren't useful began to be corrected. And in all of these, scholars in the North and policymakers in the North really gave leeway to policymakers and scientists in the South and said, give direction to this. And I was very privileged to be part of all of these. The first is the Interagency Task Team on Children and AIDS, the Joint Learning Initiative on Children and AIDS, and the Coalition for Children Affected by AIDS. The IATT on Children and AIDS is part of the UN structure. There are several IATTs on education and HIV, on PMTCT, and so on. But this brings together all of the multinational organizations. It brings together the bilaterals, brings together national NGOs, and every second year has a Global Partners Forum, a declaration to the major funders, which are mainly the bilateral funders, the country funders, on what really they should be funding, what is the new policy direction. And this has given a major vehicle to this corrective community of things that need to be put out, and it's helped enormously. The second was the Joint Learning Initiative on Children and HIV and AIDS, and this was an exceptional initiative. It was launched in 2006, driven by Lincoln Chen, and it was modeled on something else called the Joint Learning Initiative on Human Resources for Health. So it is a mechanism for tackling problems that have multiple dimensions, that exist globally, where a solution to the problem in one country has repercussions on another. And Lincoln brought together really exceptional leaders. So to give you an example, Jim Kim, who's now the head of the World Bank, was one of the Jamaica leaders, as was Agnes Bienwa, who's now the Minister of Health in Rwanda. And what it did was assemble in all the regions of the world experts to meet, to look at the evidence, to draw on the experience in the field from implementers, and then summarized those and made a set of recommendations. And I presented them at the International AIDS Society in Mexico, and the findings were published in 2009. And then, a miracle of miracles, Jamaica disbanded. It could have become one of these self-serving organizations that just went on. It disbanded. It said, we've done our work. But it became the really authoritative instrument for disseminating knowledge in this field. The final report was called Facing the Facts on Children, AIDS and Poverty, pointed to the ways in which the response to date had been flawed, and then posed three big new policy directions. The direction that we shouldn't be targeting children directly. It's too much of a moving target. It is stigmatizing. And out of this came the concept, which is now widely used in UN AIDS and other organizations, USAID, of an AIDS-sensitive versus an AIDS-targeted response. The idea of strengthening families and communities rather than replacing them, and addressing family poverty. And just to bring this piece about strengthening rather than replacing home to you, I remember when it really occurred to me what was happening. I was in a clinic. There was a very thin, obviously destitute mother with a 2-year-old and a baby in her arms, waiting her turn in the clinic, and a young volunteer walked up to her and gave her child, her 2-year-old, a doll as part of a doll project, wanting to help children. And I looked at this mother's face, and I could just see the mix of emotion of a woman who could barely feed her own children and feeling completely displaced, humiliated, maybe ashamed that a stranger was giving something that gave her child so much pleasure. And how different this could have been if the young volunteer had said to the mother, I have something for you. I'd like you to give it to your child when you find a good opportunity to do so. But it was just it was sort of iconic of this replacing a family rather than assisting them. And so the emphasis in the Jamaica was on family poverty and economic strengthening, that really focusing on once HIV hits a household, it impoverishes the household. And it limits the household's ability to respond to and protect children. Where families have assets and savings, they are usually able to continue to provide a fairly normal environment for children. But that it also limits the uptake of preventive and treatment services, and it potentiates the spread of HIV through the social and economic disempowerment and exploitation of girls. So the recommendations of the JLICA were putting families at the center. What did that mean? It meant keeping parents alive, so a big push for treatment. Keeping children in families, a big push against institutionalization. Keeping families in communities, i.e. stabilizing their economic and social conditions. Building family capacity, particularly addressing parental mental health and supporting parenting, and assisting their families to retain children in education. And this introduced a huge range of social protection programs, cash transfers, insurance, livelihood programs, public works, microcredit, food distribution, and so on. So that at the Global Fund, for example, when we began to think seriously, what would we in certain countries, what would we support all out with respect to children? In some countries, we chose health insurance, because if you could support health insurance for that family, they could retain funds that they were spending on health for consumption, such as food, and also then to social protection programs, welfare programs. So this has led to an enormous growth of cash transfer programs. They are direct and efficient, much more than providing services, because services really enrich the middle classes who provide services rather than transfer funds directly to the poorest. They don't require families to have existing capacities. So one of the big dilemmas that occurred is that a livelihood or microcredit program would be targeting the most vulnerable families, but that would be a family of an old woman with 3 young children. They really had very little capacity for working, so that a direct cash transfer, and one of the pilot programs in Kagera in Tanzania has actually led to the first pilot of an old age pension in Tanzania, which works out is very well targeted for young children. Cash transfers increase livelihoods, they address gender inequalities, they can act as a springboard to other services, and children benefit. Now, there are 2 kinds of cash transfers happening in the HIV field, but very exciting areas. The one is the prevention effects that can be achieved. Those are the direct cash transfers. They're often small pilot projects or tests of concept in which cash is given to particularly young girls to keep them in school or prevent them getting infected with STIs and HIV. And then these indirect cash transfers, which are much more like they're integrated into social welfare programs, are addressing the care and support needs of families rather than directly affecting, trying to affect prevention, but which seem, in several evaluations now, seem to actually do have some kind of inhibiting effect on HIV transmission indirectly through perhaps preventing or ameliorating the effects of early child abuse, exploitation of women, the desperation of hunger of young women, and selling sex, and so on. And so we've seen this massive expansion of cash transfer programs in Africa. 35 countries now have one or other, and they vary from programs being run by an international NGO to South Africa's, which is a strong welfare program modeled on the more European and British systems, where we have 8 million children on a child support grant of $30 a month, paid for every child who's income eligible, which actually constitutes 65% of the population. And many of these cash transfer programs began as care and support programs for children affected by HIV and AIDS. So there's been a massive spin-off effect from the JLICA, which came out so strongly for this. The Coalition on Children Affected by AIDS is a small group of medium-sized foundations and some technical people, which was formed in 2004. We were all at the Bangkok conference, and the stage was filled with little dancing, half-naked, little orphan children. And yet, these were the films being showed, and yet there was nothing on the program about children, nothing about how. And we were all so outraged, we formed this coalition. Now today, this coalition convenes a symposium, which is officially an International AIDS Society event. It occurs just the 2 days before. We give a research prize at the International AIDS Society. We undertake technical work. For example, many people who are members of key populations have children who are kept out of services because they're so afraid that if their children encounter health services or social services, they'll be taken away from them. There'll just be the prejudicial response that if you're a drug user, you can't be a good mother. And so the coalition is busy writing guidelines on the sort of decisions that have to be taken that both retain children in families for as long as possible, but also are aware of dangers and when children may need to be removed from the family for a short period to help the family stabilize. We also convene a 2-year thematic set of meetings, and we publish a special journal issue in every one of those. And I've been very privileged and honored to be the guest editor for all 4 of the journals. And they've made a huge difference because they've actually elevated implementation work in many of these countries into kind of scientific published work. So the first one was on the JAICA findings around families, which really spoke to HIV as a family disease. 60 to 85% of horizontal infection occurs between cohabiting spouses, and 90% of vertical infection is from a parent to a child. So it is transmitted within families, and by families I mean the broadest possible ideas of families rather than any restrictive notion of families. And that these impacts are similar whether you look at low prevalence areas, that it's poverty and stigma which is most damaging to children, and that supporting families is critical in all of this. The second paper really the second journal, which came out in 2010, spoke about family-centered services. And here we made a very strong coalition with GNP+, Global Network of People Living with HIV, and really brought together a community of drug users, of sex workers, men who have sex with men, to talk very openly and with great advocacy, including papers from India on studies amongst men who have sex with men, to really bring together this notion of the families of people in key populations and how much their children were marginalized in the epidemic because of the prejudices against them as parents. In 2012, we did another issue of JIAS on community action. It was part of the concerted effort of bringing to zero the infections in young children. Again, we had a very strong coalition with GNP Plus and the International Council of Women who themselves were infected. We made it possible for them to write an editorial and a commentary on the whole issue, which I think is the first time that affected people have been brought formally into a scientific enterprise. And 2014, we're bringing out a very exciting new issue in Melbourne in July on children born into families affected by HIV, really going from protected fertility decisions right through to feeding options, to interventions in schools, in families, and so on. And again, have a affected community as an integrated ICW has a formal paper evaluating their response because they've been working on country-level implementation of the IATT on prevention of mother-to-child transmission. So all these efforts, the wrong directions we took in the beginning, the correcting effect of these 3 global kind of collaborations have really had an impact in this field. It definitely led to better programs and services. There are some studies which show this, that agencies are more aligned with each other around core family strengthening activities, economic support, parent and family support, social services, better alignment with government programs so that international agencies are working to complement and build government systems, and greater impacts, particularly on the social protection front, seeing impacts on education, on nutrition, so on. And on the global funding and policy, we've seen a greater impact. PEPFAR, in its new guidance, is completely aligned with these recommendations. UNAIDS brought out a business case on social protection in which very strongly argued about the impoverishing effects of HIV on individuals and families. The AIDS research agenda is beginning to be affected by this, so that on the PEPFAR Scientific Advisory Board, we now have a child and adolescent working group, which begins to influence the kind of decisions about what is the big research areas to be involved in. And I just wanted to close by talking about, these are just the illustrations, about this leapfrogging exercise. So rather than kind of one step in front of the other, PEPFAR funded us to run an 18-month process in which we first of all, again, took stock. We got the best people together. We commissioned 3 papers, one on the psychological effects of HIV on children, a second on the social impacts of HIV on children, and the third on the health impacts. We summarized those papers. We then brought together the world's experts in areas of the study of child development related, so the impact of violence on children, impact of death on children, disrupted attachment on children, early undernutrition. And we brought those experts together and we said, this is what we know about HIV. You've been studying these other things for 20 and 30 years. I mean, for example, we have the Guatemala cohort study, where 40 years after nutrition intervention in infancy, you're seeing income differentials of 30 to 40% in adulthood. So we said, we know a lot. And we've begun to put them together, and together with a very high-level mathematics and epidemiological team, have built models on how we can make predictions about key experiences in childhood that are occasioned by HIV that are going to have long-term impacts on children. And it's beginning to really influence the way we think about targeted interventions for children affected by AIDS and much broader platform-type interventions. And these 3 papers are the front end of the journal that's going to be launched in Melbourne in July. And it brings me a great deal of happiness because I'm just going to share a little personal anecdote. In 2004, I was commissioned by the World Health Organization to do a review on the importance of parent-child interactions for the survival, growth, and development of children. And I was doing the research in Geneva in the WHO library, and I came across the fact that in 1948, the WHO had commissioned John Bowlby. Now, John, if you're in child development field, John Bowlby and attachment it's the kind of biblical piece. And WHO had disseminated his monograph, The Maternal Care and Mental Health. They'd commissioned it because of the huge numbers of homeless children and displaced children after World War II. And in 1953 to 1955, they hosted 4 meetings of the most famous people who were working on, these weren't child development people, they were working in areas of science that interfaced with child development. So John Bowlby, Erik Erikson, Harry Harlow, Barbel Hinhilder, Ludwig von Bertalanffy, Conrad Lorenz, Julian Huxley. And I remember reading this, and it was a time I was beginning to think about HIV in children. And I was thinking, why can't we do something like this? Bring the best people together and be able to put our minds in a concerted and consolidated way to the problems of children in HIV and AIDS. And this PEPFAR-funded project that I've told you about over the last 18 months is exactly what we have done. And I kind of feel, at last, children affected by HIV and AIDS have got something of what they deserve. Thank you.